Good morning, everyone. Today's topic of discussion is stainless steel crowns. So today I'll be dealing this topic on various subheadings, that is introduction, the advantages of using stainless steel crowns in primary tooth, then the indications, contraindications, the clinical procedures for fabricating a stainless steel crown, then the complications in relation to the stainless steel crown fabrication, then clinical modifications. So coming to introduction, the stainless steel crown, it's also known as a preformed metal crowns, and it's used in primary tooth. It's used as a semi-permanent restoration in primary tooth as well as young permanent tooth, which requires the crown for a certain period of time. So the stainless steel crown was first described in 1950 by Engel and followed by Dr. William Humphrey in 1950. Now, what are its advantages of using in distress dentition? Because you know that a primary tooth, the crown structure is very minimal. So often what happens is the neglected caries can destroy the entire tooth structure, leading to multi-surface caries lesions. So we can go for a single semi-permanent restorations like SS crown instead of multi-surface restorations. They are acceptable for both patient and the dentist, and they are also more cost effective, and the patient can perform a regular masticatory function. And the tooth preparation required for a stainless steel crown is minimal. We can do it in a single appointment because various stainless steel crowns are available in the market now, depending upon the different sizes of the tooth and different particular tooth, whether it's a primary first molar or second molar, maxillary or mandibular. So we can select the size according to the patient's mesodistal dimension of the crown, and then we can fabricate the crown in a single appointment. Now, what are the indications of stainless steel crown? So normally we restore the primary tooth with multi-surface caries lesions. That is, we need not go for a different restorations on each aspect, mesial, distal, occlusal, like that. So if a primary tooth is affected with a multi-surface caries lesion, we can go for a stainless steel crown. Then in cases where there are enamel defects, hypoplastic defects of primary or permanent tooth, we can go for a stainless steel crown, especially the molars. Then following a pulpectomy or a pulpotomy procedure as a post-endodontic restoration, so that the patient can perform the masticatory functions. Even before, in ancient times, there was a stainless steel crown with respect to the anteriors, but now it's all outdated. It is unaesthetic. Now various modifications have come for the anterior tooth where they are using open face stainless steel crown. But now this is also gone out of market because now various aesthetic crowns are available. This is one of the modification which I'm showing. It's an open face stainless steel crown which was used before for the multi-surface caries lesion in case of anterior primary tooth. And other indications are where we can use it in medically compromised patients where they can't maintain a proper oral hygiene and who are more prone to caries. So we can go for disabled individuals, restorations in disabled individuals. And another indication is as an abutment for space maintainer. So in this picture, you can see it's a crown and loop space maintainer. So what happens is if the abutment tooth is a multi-surface carious tooth or a tooth which is undergone a pulpectomy or a pulpotomy procedure, so if the abutment tooth requires a crown, so we go for a space maintainer. That is, this is crown and loop. So one of the indication of the stainless steel crown is as an abutment for the space maintainer. Then we can give stainless steel crown as a temporary restoration in case of a fractured tooth in order to maintain the medicament. That is in case of pulp capping procedures. Then certain patients with cases of bruxism where there is severe attrition and there is chances of pulpal exposure, we can prevent the pulpal exposure by going for the stainless steel crown. Then another modification of stainless steel crown is reverse stainless steel crown, where in case of a single tooth cross bite, we put the stainless steel crown in opposite direction so that a 45-degree angle is maintained so that it will help in the correction of a single tooth crossbite. So this is a reverse stainless steel crown. Now coming to contraindications, normally we don't go for a stainless steel crown for a primary tooth which is nearing the exfoliation time. That is if the root length is less than half. So normally we don't go for a stainless steel crown as you see in this picture. Now coming to the composition, the various types of crowns are stainless steel crown as well as a nickel based crown. The composition of stainless steel crown, the chromium content is 17 to 19%. And nickel 10 to 13%, iron 67, and minor elements 4%. And in nickel-based crowns, the advantages, it's easy to adapt and they have increased wear resistance. But disadvantages, we can't go for the patients who have allergic to nickel because the content of nickel in this nickel-based crown is almost 72%. Now, I told you previously, various types of stainless steel crowns are available in the market in the name of Rocky Mountain, Omco Company, Unitech, 3M Company. So the various sizes as shown in the pictures. This is a 3M stainless steel crown where the sizes are available from 2, 3, 4, 5, 6, and 7. So according to the patient's tooth dimension, we can select the crown. Now the classification based on shape is, it's classified into 3 types: untrimmed, pre-trimmed, and pre-contoured. So untrimmed crowns, the crowns is neither trimmed nor contoured. You can see that's almost straight here and it's not contoured also. So this requires, the disadvantage of this type of crown is that it requires a lot of adaptation. So it's time consuming. So example is Rocky Mountain, okay. So pre-trimmed crowns, the second pre-trimmed crowns, these are the crowns which are straight and non-contoured sides, but festooned. This is festooned to follow a line parallel to the gingival crest, something like this. So they still require contouring and some trimming. The crowns, normally what we use, example as 3M crowns, they are known as pre-contoured crowns. They are festooned and pre-contoured also. So we require just a minimal amount of festooning and trimming during the fabrication procedure. Now coming to the clinical steps. What are the clinical steps we have to do before going for a stainless steel crown fabrication? First and foremost, we have to go for a pre-operative crown evaluation about the size of the crown, opposing tooth, if whether the opposing tooth is supra-erected. So we have to have a clinical picture. Then next is the step is the crown selection. So we have to, I told you, there are various sizes available. So depending upon the size pertaining to that particular patient, we have to select from the kit. We have to select the crown, which size is available. Then we go for a LA administration. Then we have to go for an isolation technique like rubber dam application, placement of the wedges, etc. Then we come to the procedure, clinical procedure, that is tooth preparation. And tooth preparation we have again, it's under subheadings that I'll come to it. Then trial fitting, then finishing and polishing, then cementation of the crown, then the instructions what we have to give the patients. So crown selection, we first have to check the mesodistal width of the crown. There are various methods, trial and error method, or we can use body's gauges to measure the mesodistal width of the crown. So we have to see for the occlusal anatomy, the height of the crown, everything before selecting a crown. Then even the gingival margin contour also plays an important role, because normally what happens is in a primary tooth, the primary second molar, the buccal aspect, you have a smile line pattern, the gingival margin contour, and the first molar, primary first molar, because of the mesial cervical bulge, you have a stretched pattern. So we also have to check the gingival margin contour of the crown. And this is the proximal aspect where you have the frown-like pattern. Now coming to the tooth preparation, what are the aims of tooth preparation? One is to provide the sufficient space for the crown, then to remove the caries, then to leave the sufficient tooth structure for the retention of the crown. Now I told you earlier that the tooth reduction, it has various steps, that is mainly 3 steps are there. Various authors have given different theory of thought. So according to one particular thing, we can divide the tooth preparation into occlusal reduction, proximal reduction, and buccolingual reduction. Now, occlusal reduction, it is done with a burr number 330 or A69 or 169L burr. And usually the occlusal reduction, as you see in this picture, it's done 1 to 1.5 mm. We take the reference from the marginal ridge of the adjacent tooth. So it's usually 1 to 1.5 mm reduction of occlusion is done. And then once the reduction is done, we have to round off the sharp line angles. Then next we proceed with the proximal reduction. So this is done using 169 L burr, and then it's done in a buccolingual direction. Okay. So usually what happens is we have to separate 1 to 2 mm away from the adjacent tooth, the proximal reduction. There should be a clearance of 1 to 2 mm away from the adjacent tooth. And make sure you don't make ledges on the proximal aspect when you do a proximal reduction, because it's very, very important. If you cause a ledge formation, then it results in ill-fitting crowns. So not to same thing, lead should not be formed. This is a proper placement of the crown. Then buccolingual reduction, actually we do minimal buccolingual reduction, but I told you in case of the primary first molar where there's a mesial cervical bulge, if it's more prominent, we'll have to slightly reduce 0.5 mm for that, so that the crown easily fits in. We have to maintain the prominent cervical bulge of the primary tooth, which aids in more retention of the crown. So this is a proximal reduction. It's done. Occlusal reduction. Once the tooth preparation is done, we have to evaluate, see for the occlusal clearance, whether it's 1 to 1.5 mm. Then we have to see that whether proximal slides are converging occlusally. Then we have to pass an explorer tip through the prepared tooth to see whether there is a ledge formation at the proximal side. So I told you buccal and lingual reduction, it should be minimal. It's just 0.5 mm. And buccal and lingual wall should be converging occlusally. Once you evaluate the occlusal clearance, everything, then we go for a trial fitting and trimming the crown. So we have to try the crown on the tooth. First, normally we place it on the lingual side and then slide it over the buccal side. Then once the crown is seated, we mark it. We have to place it in the lingual, then slide it over the buccal side. Then we mark it with a, you can use an ultrasonic scaler or a marking pencil. And then we just remove the excess crown with the crown cutting scissor, so that only 1 mm extends into the gingival sulcus. And once it is done, we go for a finishing and polishing. We festoon the crown according to the gingival margin contour. And this is how it should be 1 mm into the gingival sulcus. Otherwise, it's going to cause blanching of the gingival tissues. Then once it is done, once you feel that it's gone 1 mm into the gingival sulcus, then we go for a contouring and crimping of the crown. Contouring, normally we use a ball and socket contouring plier, and it's done in the middle third. And crimping, it is done at the gingival third with a crimping plier. So crimping is usually done to adapt the crown into the gingival aspect of the tooth, so that the leaching of the luting cement is prevented, and also it doesn't irritate the gingival tissues. Once everything is done, then finishing and polishing. Then once you check for the, then remove the rubber dam and then check for the occlusion. After that, we go for the cementation of the crown. Various cements can be used in phosphate, polycarboxylate, or type 1 glass ionomer cement. So most preferred is resin modified glass ionomer cement. We just fill the crown, approximately 2/3 of the crown with the cement. Before cementation, it's better we apply petroleum jelly onto the soft tissue, so that the cement doesn't stick onto the soft tissues. Then once the crown is filled, 2/3 of the crown is filled with the luting cement, then we place the crown from the lingual side and then slide it over the buccal and ask the patient to bite in a centric occlusion. Then after that, we remove the crown with a explorer tip, and from the proximal aspect, we can use the excess cement using a knotted dental floss. So this is the picture, and this is a ring move. After that, you have to re-examine the patient, check for the occlusion. And now what are the post-insertion instructions you give? We ask the patient to avoid chewing with that crown for 1 day and not to take water for half an hour till the instruction should be given for maintaining oral hygiene. And patient should be recalled every 6 months. Now, what are the causes of stainless steel crown failures? One is poor tooth preparation, then poor crown adaptation leading to poor retention, then improper cementation methods, failure of pulp treatment. If your pulpal therapy is failure, then even your crown goes for a failure. Then recurrent caries. If you don't remove the caries in case of multi-surface caries tooth before going for a crown, if you don't remove the caries, there is chances of recurrent caries. Then complications of stainless steel crown is, as I've told before, if you don't do a proper proximal reduction, it can lead to the formation of interproximal ledge, which during which the crown cementation will be very difficult. Then crown tilt. If you remove excess of buccal cervical bulge or lingual bulge, there is a chance of crown tilt if excess tooth structure is lost during preparation. Then poor margins. If you don't properly festune the crown margins, then it's going to irritate the gingiva and it acts as more plaque retentive area, leading to gingival inflammation or gingivitis. Then another complication during the stainless steel crown fabrication is the inhalation or ingestion of the crown. So it's better we go for isolation techniques like rubber dam, or at least by using a throat shield, we can prevent the ingestion or inhalation. So this is a picture of throat shield. Now, what are the modifications of stainless steel crown? This I've already told about the reverse stainless steel crown, where you place the crown in the opposite direction so that a 45-degree angle is maintained and you can correct a single tooth cross bite. So this is a reverse stainless steel crown. Then next is the open face stainless steel crown, which was used before for the anterior tooth. So this is the procedure done where tooth preparation is done. Then we place the crown. Then a window is created on the labial aspect and we go for a restoration with composite. It was done before. Then stainless steel crowns with laboratory facings. These are the modifications. Then another modification based on the stainless steel crown size. If suppose your tooth structure is, you have an oversized crown with you, so how can you adapt the crown? So normally what we do is we cut the crown and then we overlap the cut edges and weld it together so that the size of the crown can be reduced. And what in case of undersized crowns? So what normally we do is we give a V-shaped slit and then we take another band material and weld it and then we go for the adaptation of the crown. And this is in case of deep proximal lesions where there is a shortage of crown. So normally what we do is we weld a band onto that particular area of the crown and then we go for the crown cementation. So coming to the conclusion, stainless steel crown are semi-permanent restorations which can help us to maintain the deciduous teeth till the normal exfoliation time so that the child can perform the masticatory function and which will improve the general health of the patient. Thank you.